So we're going to switch gears and talk about, another aspect of adult transplantation that had a major development in the past 2 years, which is kidney xenotransplantation. If we put kidney transplant in perspective, we did our first successful kidney transplant back in 1954, and kidney transplantation became the best treatment option for the majority of patients with renal failure. The question is, that in those 70 years, there are a few things that are still major barriers for the long-term success of transplant. We have immunological barriers, so the need for lifelong toxic immunosuppressive therapies to prevent rejection. So that's still one of the key aspects that unfortunately limits what we do. We also think about disease recurrence. And we gave the example of membranous nephropathy, but there are other diseases that unfortunately impact how long these kidneys last. And third of all, we'll talk about organ shortage. And this is clearly the bottleneck of transplantation. So we have more patients on the waiting list that we have organs to provide to them. So this limits significantly how many patients we are able to transplant. And so what we've been doing in the research side is sort of trying to attack those three main areas. So number one, can we use our immune system in a smarter way? Can you use the immune regulatory mechanisms that exist in order to minimize the requirement for anti-rejection meds after transplantation? Second, can we risk stratify and look for biomarkers that might predict us how much recurrence may occur, when this recurrence may occur, and do we need to deploy any specific therapy? And last of all, to address the organ shortage, can we use organs different than our own humans from decedent, from cadaveric or living donors, such as animal organs, or even bioengineering of organs in the lab in order to overcome the organ shortage? We are going to be focusing mostly today on the next 25 minutes on xenotransplantation. And this is, I think, a curve that most of you have seen, that in the US we have over 100,000 patients on the waiting list, and we only perform about 48,000 transplants a year, and our waiting list keeps growing. So this is a national program, but also a problem from individual centers where we list more patients that we transplant every year, so our list keeps accumulating. What's the problem about it is that while our patients are waiting to get to the top of the list, they have to remain on dialysis, which has a huge impact in the quality of life of our patients. But not only that, it has a major impact in their morbidity and mortality. So the risk of dying while you're on dialysis is six-fold higher than if you get a transplant. And to put in perspective, the average wait time for a transplant in the US, if you don't have a living donor, is around 5 years. So these patients have to, most of them remain on dialysis for 4 to 5 years until they get to the top of the list. So this creates a major dilemma. And our patients are very vocal about it, that, life with dialysis is pretty miserable. So we have to find a solution to that. And there's not only one strategy. We can think about expanding the use of marginal donors. We can think about removing barriers for living donation, so more living donors can sort of, come in and donate their organs to remove patients from the waiting list. But the two more innovative ways of addressing that is bioengineering of kidneys and xenotransplantation. Bioengineering of kidneys had a major development also in the past 10 years, in part because we are able to get stem cells, so very mature cells, and differentiate into all mature kidney cells. And so here, what I'm showing you is an organoid that has both proximal and distal tubules. It has podocytes. It has the endothelial cells. And on the right side is a stem cell that was developed into ureteric buds. And if you mix them together, you're actually able to bioprint these organs, put an inflow and an outflow as a drainage system, as you can see here. and start implanting this into mice in order to optimize their structure and be able to produce urine. So this is work that was recently published by our lab in collaboration with the Lewis and Morazzani lab, who are two amazing developmental biologists, and in trying to address this by using bioprinting to produce these organs and outcome. But I have to say that one of the biggest challenges that we have in reproducing the kidney is its efficiency. So the kidney is 99.9% efficient in filtering the blood and producing a very small amount of urine with exactly the things that we need to excrete. And so far, it's hard to reproduce that biology if you're creating that structure solely in the lab. But xenotransplantation, I would say, is in a completely different stage because we are using animals that have their own developmental biology to create these organs from scratch. And in our case, we're going to be talking about kidneys from genetically modified pigs. And why do we use pigs compared to other animals? There are a few reasons. So organs from pigs have a very similar size and function to humans. Most importantly is the scalability. So because pigs have a short gestation, around 3.5 months, you can quickly breed these pigs, and the piglets we can use by 1 year as a source of organs. So if in one gestation you may have 6 to 12 piglets that within 1 year you can use it, you can nearly escalate and potentiate the use of organs. I think another aspect is that there's already some acceptability in using pig products such as heart valves and cartilage from pigs in humans, but there are certain challenges when you're using the entire organ. Most of it is related to some immunological incompatibilities. So pigs and humans separated more than 80 million years ago, and pigs have certain sugars in which we have natural antibodies against, a little bit like the ABO blood groups, if you think about it. And so if you transplant an organ right away, they can cause an immediate rejection. And there are a few physiological differences. Our complement or coagulation system has more regulation than the pigs have. And most concerning from the regulatory perspective is the potential of transmitting a new zoonotic infection. So a new infection that is only present in pigs that suddenly, because we're doing xenotransplants, we may be transmitting into humans. And one of these infections could be what we call porcine endogenous retroviruses, or PERVs. And these are viruses that are inside the DNA of the pig that have a high capability of potentially infecting human cells, although no infection have ever been documented so far in humans. This is not a new concept that we're thinking about using animal organs. If you go back to 1906, Mathieu Jaboulet in the University of Lyon, he actually connected a pig kidney into a female who had 48 years old and had renal failure. And the kidney made urine in the first 24 hours, but eventually thrombosed by day 3. But the idea of using animal organs was always there. This is what happens if you transplant a wild-type pig into a monkey. Within the first few minutes, everything looks great, but if you wait a little longer, what you start seeing is that the entire organ gets thrombosed. And it gets thrombosed in part because of these natural antibodies that cause what we call a hyperacute rejection. Why suddenly now we're talking about xenotransplantation? So there has been, two major tools that have changed the way we think about xenotransplant and we adapt. Number one, we have this magical scissors, which is a CRISPR-Cas gene editing tool that allow us to modify the gene in a very precise manner, very efficiently and rapid, and perform multiple alterations in the same DNA material. So this creates a lot of efficiency in cloning these animals, in creating animals that could be more compatible once we understand the biology behind. And the second aspect has been the use of what we call co-stimulation blockade with anti-CD154 antibody. So these are unique immune suppressive drugs. They are capable of controlling the immune response, but they're very powerful in suppressing B cells and antibody production. So it's a unique scenario for us to be able to modify the gene, creating more compatible organs, and also using more powerful drugs that together made the secret sauce for us to see improvement in these kidney survivals. And this is just to show you how much research can be challenging, that in the 1980s, for close to 20 years, the longest surviving pig kidney to monkey was 22 days. Okay, that was a single animal. If you go back now to 2000, 2010, the first knockout animals were created, and the Gall knockout was the first pig that we used for transplant. And the maximum survival of one single animal was 83 days. But then you go to after 2012, when CRISPR-Cas gene editing was applied and allow us to perform multiple alterations, both removal of certain genes as well as the addition of human genes. And suddenly we had a survival that surpassed 1 year in monkeys. And then in 2023, Mass General published its work at Nature showing now pigs surviving more than 2 years in monkeys. Remembering that performing transplants in monkeys is much more challenging than humans, in particular for keeping them long-term because of the limitations in both diagnostics as well as in immune suppressive drugs. So the pig that we decided to move on to the clinic was what we call a Yucatan pig, which is a mini swine. So these are pigs, they're slightly smaller than a regular pig. They have 75 to 100 kilos. And there were multiple genes that were altered here. So the most important ones to know about was that there were 3 pig carbohydrates that were deleted. So these are pig carbohydrates in which humans have natural antibodies against. We inactivated all pig endogenous retroviruses. So this creates a scenario in which we bring to close to zero the risk of transmitting these pervs into humans. And then we added a cassette with some human transgenes. So these are complement inhibitors, anticoagulants, as well as immune regulators that would allow us to be able to better control the immune response in the setting of the xenotransplant. But one of the critical questions was, how do we move this from the lab to the clinic? And what the FDA allows us to do is to apply for what we call a compassionate use application, which is a very specific regulatory pathway inside the FDA that allows us to use a new therapy without being yet on a large clinical trial in a patient who has no other options. And of course, one of the key questions here is, who is this patient that we want to try to do this therapy? Because as you can see, there will be a lot of confounding factors depending on the patient that we selected. So after 2 years, we selected this 62-year-old male who had diabetes as the cause of kidney disease. He was on dialysis from 2011, 2018, ended up getting a kidney transplant that lasted about 4 years, and then he went back on dialysis in 2022. What he was facing is the challenge of many patients that had been on dialysis for long term. He was losing his access. So he had a femoral AV graft on the right side that clotted. He got a left tunnel catheter on his left femoral vein that was functioning, but it was associated with significant pain and recurrent admissions to the hospital. And he already had a huge burden of cardiovascular disease, so severe calcifications, as you can see here on the CAT scan here, as well as a known history of heart failure and coronary artery disease. So the biggest question is, could this patient wait another 4 to 5 years to get to the top of the list to get a human kidney transplant, or would he not make that? And if we look at overall, most patients who have a similar characteristics as these patients, unfortunately, they do not make to the top of the list. They ended up dying or becoming too sick while they wait on transplantation. This is a nice calculator from the European group in which they plot the chronological age of our patient, how long they've been on dialysis, and what's their life expectancy. As you can see here, the chronological age of 62-year-old who has diabetes and has been on dialysis is similar to a biological age of 85. So there's a very accelerated aging of almost 23 years of these patients. So, and this is where, unfortunately, these patients ended up becoming so sick and die while they wait on dialysis. The second aspect, once we selected the patient, is defining what type of immune suppressive therapy we were planning to use, and thinking about both an induction and maintenance therapy. So the induction is a little more immune suppression that we tend to use on a regular patient. So we involve both a B and a T cell depletion, complement inhibition, and steroids. And the maintenance was a quadruple immune suppression therapy. So a co-stimulation blockade with anti-CD154, a calcineurin inhibitor such as tacrolimus, mycophenolate, and low-dose steroids, okay? And with that regimen, and why this anti-CD154 is so important is because of its very powerful effect in suppressing B-cell activation and antibody production. But not only that, across all the immune suppressive drugs, this drug is also capable of inhibiting the innate immune cells, in particular myeloid cells, which is something very unique. Most of our drugs that we use post-transplant are more focused on both T and B cells, mostly T cell suppression, and so this is also capable of inhibiting the innate immune side. So in March 2024, so we performed the first xenotransplant in a human living being. So this was the pictures from the procurement. So when we were harvesting the organ, they wouldn't allow us to bring the pig into the hospital, so this was done in an outside facility, in an operating room. As you can see here, the kidney on the middle, and our surgeons sort of working on dissecting and preparing the kidney for transplantation in cold storage. The surgery itself took about 4 hours. The reason it took a little longer was related to the significant calcifications of this patient that made the connection of the artery and vein much more challenging than usual. But after 4 hours, the kidney actually perfused really well. And most exciting of all, within minutes after reperfusion of the kidney, this is the ureter before it actually gets connected to the bladder, we could see urine being produced, and more than 2 liters of urine was produced within the first 24 hours with no evidence of hyperacute rejection. As a nephrologist, we were very worried about our electrolytes, and as you can see here, throughout the 51 days that this patient was monitored, we didn't see any major event of hyperkalemia or hypokalemia. Water balance was also very well controlled, so the thermostat of the pig kidney is very similar to humans in terms of maintaining all these electrolytes in a very balanced level as expected in humans. If you give it and perform an ultrasound with echo Dopplers, what you see here is a very similar picture as in a human kidney. In terms of shape, in terms of blood flows, these are the velocities and the resistive index. So they look very, very similar. And what we observe here is that the serum creatinine quickly came down. There was a slight bump in creatinine around day 9. We biopsy and we identified a cellular rejection event, and after treatment, this creatinine further lowered down, and during the subsequent few weeks, you can nicely see this creatinine leveling off on a very stable pattern throughout. Our patient got discharged home on day 18. We were able to remove his hemodialysis line. All electrolytes remained stable, and he had overall a very good urine output with an average creatinine around 1.7 milligrams per deciliter. Once they were in the outside setting, we were doing labs frequently, 3 times a week initially, so in order for us to detect any problems. We didn't see any major issues with blood pressure control, which was also something that some concerns have been raised. And what was interesting is that we have some work that was published on Nature Communications that goes into details, but it does seem that renin and the renin-angiotensin-aldosterone system is not activated in the pig kidney because of some discordance in the binding sites. But despite that, truly, we are able to maintain blood pressure without the RAS system. So this, I think, was a very important observation throughout the 51 days that this patient was followed. So this was a cellular rejection that occurred sort of very early on day 8 after transplantation. Was a cellular rejection, not antibody mediated. It was predominantly CD3 T cells and macrophages, and with the usual treatment, so thymoglobulin, so a T-cell depletion, and steroids were able to control that. We added some complement inhibition, C3. We were mostly doing anti-C5 on the initial trial, and you can see here that we were able to also get the C3 staining down on the biopsy, and we did some adjustments of both tacrolimus and mycophenolate. Importantly, when we look at all the potential xenopathogens that could be transmitted, we monitor these on a regular basis, weekly for the first month, and then every 2 weeks following. We did not observe any transmission of a zoonotic infection into the recipient. On day 52, unfortunately, the patient was seen in clinic. We got some labs, and on the evening, he started not feeling so well, and he ended up having an arrhythmia and passing. What we see here is the kidney at autopsy, and as you observe here, there was no evidence of rejection and no evidence of any potential connection between what happened with the xenograft and what happened with the patient. This first case allows us to really dive deep, provide a very granular analysis of everything that was happening. So the clinical case was published in detail in the New England Journal of Medicine, but there were two important publications that came out of it. One was characterizing the immune profiling both in the blood as well as inside the kidney that came out on Nature Medicine late last year, and then, or actually early this year. And then also another paper who dove into details about the physiology of this pig kidney. What are some things that are very similar? What are some things that are very different that we won't have time to go into too much details, but these are some references. So what do we learn with this first case? That number one, hyperacute rejection can now be prevented with the gene editing strategy that we apply. Number two, that the physiological kidney function is achievable in humans, very similar to what we had observed in non-human primates. 3, cellular rejection can happen, but it's manageable. And we did not observe any zoonotic infection with the protocol that we have deployed. So, of course, this was a short follow-up of 51 days, and the most important thing was to get more experience, do more cases, and expand our knowledge so that we can learn what are some of the remaining challenges of xenotransplantation moving to the clinic. I won't have time to dive into too much details, but this is just to give you a flavor of all the analysis that we have performed in my lab, looking at what was happening immunologically with this recipient, including single-cell RNA-seq, proteomics, metabolomics, tissue transcriptomics, multiplex immunofluorescence, and so forth, and using then machine learning in order for us to try to digest all this information and depict the picture that we observe. And how is this different to human kidney transplantation, which is a very important aspect. I think across all these technologies, the one that can provide very quick data that may actually help with management is the multiplex immunofluorescence. And the reason why this is important, because in a single slide of paraffin, you are able to actually use 16 up to 32 different antibodies and have a clear picture of what's happening with the immune cells that are invading the tissue, where are they located, how much activation you have, how much regulation, and so forth. And so we won't have time to go into too much detail there, but it's really a technology that's going to change how we manage xenotransplants, but I think definitely it's going to move on to human kidney transplants as well, allowing us to better analyze what's happening immunologically on these patients. So what happened since that first case? We performed 4 additional transplants. These transplants are now ongoing. And some are passing already 9 months of transplantation. But what's exciting is what's coming next. We have a large now multi-center study. They had a very simple inclusion criteria. We're looking at patients between the age of 50 and 70 who are on dialysis for at least 3 months and that are unlikely to receive a timely human transplant, meaning if we look and they don't have any living donors, and depending on their blood group in the region, their waiting time tends to be more than 4 to 5 years on the waiting list. And they, of course, they have to be candidates for a human kidney transplant. So we want to start with patients that we truly feel that they would benefit potentially in the future from this. And it's a phaseless study, so it progresses through multiple phases as we advance, as we collect data. So we're very excited about this expansion into from one center to a multi-center study. For patients that are interested in participating, they can get into our website, www.mghxenotransplant.org, mghxenotransplant.org, and they can provide their contact, and we can keep them updated about any changes in protocol inclusions or any other eligibility criteria that could be important. So I truly feel that that's the next revolution in kidney transplantation. So we had the first kidney transplant, human kidney transplant in 1954, the first xeno kidney transplant in 2024, 70 years later. And I think our goal is, can we have dialysis become the exception rather than the rule in the treatment of patients with kidney failure? And with that, I want to thank in particular patients. So it takes a lot of courage and trust, of course, to step in and volunteer for these trials, because truly we don't have any prior data to tell the patient of how long these kidneys are going to last, what are potential complications. There are many unknowns, and they're the true pioneers of xenotransplantation. And this is one of our patients who had a kidney for a little bit above 9 months, and he's throwing the first pitch at the Red Sox game early this June. So this is an incredible thing to witness. And this is most importantly a teamwork. So there has been more than 100 different people that were involved with this, both at MGH, our eGenesis collaborators that we work very closely, that provide us with the pig kidneys, including the FDA, other research immunologists and researchers that made this possible. So I'll stop here and be happy to take any questions. Thanks, Jamil, for the opportunity.
Oh, that was great. Thank you, Leo. I have a couple of questions for you before you leave. I know that it will be harder for you to come back for the Q&A session. One question that came your way regarding your first talk: is there any role for rituximab empirically in elevated PLA2AR in patients receiving transplant?
Yeah, that's a great question. So my feeling is yes, I think there is a role. This has to be studied in a controlled fashion, so in a research study. But I feel that based on our data, if you have a high PLA2R antibody going to transplant, we want to try to reduce these antibodies to minimize the risk of recurrence. Would I delay a transplant because of the high PLA2R? I would say no. If we have a kidney on board and the patient is either approaching dialysis or on dialysis, let's get them transplanted, just because membranous is slow progressing disease. But I would consider treating these patients and following the PLA2R antibody levels after that.
Great. So maybe another question: why isn't dapagliflozin, which is an SGLT2 inhibitor, used for post-transplant patients?
So I think they're expanding the use. Most of the early trials, even in patients with kidney disease, they excluded transplant patients, which is very common. They don't want to get into the complicated world of kidney transplantation. But what we're seeing is that more and more centers are using it. Some have tested, just clinically, adding to their protocol. Some have tested in a randomized fashion. Some have, just starting, patients on it and monitoring prospectively. So I do feel that we have good safety data so far. Would the same benefits that we're seeing in kidney disease patients will also be seen in transplanted patients? The short answer is probably yes. I don't know if it's going to be the same magnitude, but I know there are a couple of ongoing studies now. They are looking at that in a little more rigorous fashion. So I think hopefully very soon we have some of this data to support.
That's great. Thank you very much, Leo. Enjoy your vacation, and thank you for joining us from overseas for this. Thank you.
My pleasure. Thank you, guys. See you soon.